Hi everyone! So this is me and Seyma's project on congenital membranous stapes foot plate producing episodic pressure-induced perilymphatic fistula and its symptoms. So let's go back to the basics. What do we know about perilymphatic fistulas? So we know that it's an abnormal communication between the fluid-filled cochlea and the air-filled middle ear space. When perilymph leaks out of either the round or oval window, this creates this pressure change in the labyrinth and can result in hearing loss. And so some symptoms that people typically experience are tinnitus, they have oral pressure, there's sudden sensory neural hearing loss, they might have motion intolerance, and usually there's dizziness with pressure change. And so a diagnosis in the past, it's important to know that perilymphatic fistulas were observed in post-stapedectomies where perilymph leaks out of the prosthesis and into the oval window. But we also know now that it can be induced by trauma or it can be idiopathic. And so now we know that we can diagnose it with a CT, an audiogram, tympanometry, ENG, VNG, VEMS, head shake test, and usually there might be a history of head trauma. However, the diagnostic of perilymphatic fistulas is a bit controversial due to the lack of reliability in diagnostic tests. With intraoperative visualization of the perilymphatic leak, you can see it most of the time, but there's no criteria of what constitutes a leak under observation, especially since the total amount of the fluid in the cochlea is about 3 to 4 drops. Not a lot. And so with high-resolution CT scans, it's really great at visualization of air bubbles, but it's not always visual. A lot of times it can be interpreted as artifact. And we also know that it's rare. About 1.5 people have it out of 100,000. It's present in 6% of children, and it can be idiopathic. And so usually with treatment, there's 2 types. There's a conservative and there's a surgical method. And what the conservative method is, they go ahead and give you corticosteroids and put you on bed rest for 7 to 10 days. However, if symptoms still persist afterwards, there is consideration for surgical intervention. And so diagnosis involves many interprofessional practices. And so one, we know that audiologists can be involved with the hearing and vertigo test, vestibular testing, that's what I meant to say. There is a surgical team. Your PCP does need to be informed of what's going on. We also know that the ENT, they're the ones that are going to be doing the surgery. And I also forgot to mention that usually with the surgical intervention that they use a blood patch. And so the blood patch actually takes about 30 minutes with the surgery that involves lifting up the eardrum through the ear canal and placing a patch on the oval or round window. And so usually with the ENT, there's going to go ahead and be nurses to help with pre and post operative care. There's going to be ER doctors because if you have sudden sensory hearing loss, you should go straight to the emergency room. There's going to be radiologists for doing CT scans and interpreting them. And when you're in the operating room, you're going to have anesthesiologists. And so usually with either with the conservative method, you're giving corticosteroids. So that's medication that you can pick up from the pharmacy. And let's not forget our researchers. Their findings really do help with finding less invasive interventions, especially with diagnosis in this case. So let's go ahead and talk about the case study.
All right, let's talk about the subject. So the patient is a 32 years old female. Who experienced sudden sensory neural hearing loss on the right ear. It is important to know that prior to the sudden hearing loss, she had vertigo every time when she sneezes, and it will last 2 to 3 seconds. And it started when she was 17 years old, which is 15 years ago from that time. There isn't any history of traumatic events, and she had both vertigo and sudden sensory neural hearing loss, so she went to the emergency room. When she went to hospital, they gave her corticosteroids to reduce inflammation and swelling in the hearing organs, along with bed rest, which is for a week. After a bed rest, patient's vertigo symptoms resolved. But on day 8, her symptoms came back and she experienced severe rotational vertigo and persistent hearing loss. So they did perform audiometry tests and vestibular VNG tests. She had normal tympanometry test results in the both ears and unilateral severe mixed hearing loss on the right ear. In the VNG test revealed left beating horizontal and rotational nystagmus, which is mainly occurred in the supine position of the test. So on day 10, they performed CT, like patient actually subjected to the CT, which shows pneumolabyrinth in right vestibule. And they again gave her bed rest and steroids, but it didn't help her symptoms to reduce, and her symptoms were still persistent. And in this case, they decided to do a perilymphatic fistula repair surgery. And this is when they saw adhesions of stapes foot plate. They confirmed this with a CPT detection test. And they were able to repair the tear with a connective tissue to seal and stabilize the labyrinth. After the surgery, the patient's vestibular symptoms and nystagmus disappeared immediately, and her hearing showed improvement within a month.
Okay, so let's go and talk about some of these figures. So pre-operatively, when she had her audiogram, we see that in the right ear, she does have that severe mixed hearing loss. And with the CT, let's go and do a refresher. So white represents bone, gray represents tissue, and black represents airfield. And so if you look at the arrow, you can see that there are airfield spaces. And so just a diagram of this dehiscence of the stapes footplate, this is what it looks like. And then we see post the surgery that her hearing did improve at certain frequencies, and the conductive components actually and so let's go ahead and review the slots and questions. So etiology is almost always unknown. It's idiopathic, usually induced by head trauma, but if that's not the case, it's usually idiopathic. And so with the dehiscence of the stapes footplate, authors were able to discern that there was induced both through mechanical waves in the inner ear causing pressure-induced vertigo. And so typically with diagnosis, we know that the patient might experience third window symptoms. There's hearing loss, but it can also mimic Meniere's, and we also use a high resolution CT. But what the authors actually recommend for future diagnosis is to actually look at an isoform of the cochlean tomoprotein. And so what this protein is that it is actually a protein that is specific to perilymph, and it's not expressed in the CSF, blood, or saliva. And so that kind of makes it harder if we're trying to look for any markers through those ways. We actually have to go ahead and look for the isoform. And so the study that they were looking at actually saw, prior to the study, the authors actually came up with a criteria for ELISA. And so that's just, ELISA is just the criteria. And so what we know is that if there is 0.8 of this marker present, then that indicates that it's positive that there is a perilymphatic leak. If it's between 0.4 and 0.8, it's what we consider intermediate. So it's not something of concern, but it's something to watch out for. But if there is 0.4 of the biomarker or less present, then that indicates that it's negative for perilymphatic leaks. And so with the CPT, what we're actually doing right now is, okay, we're not doing it, but There is a CPT test analysis on the specific expression and diagnostic accuracy, which is being extensively studied. In June 2020, the Japanese Ministry of Health, Labor and Standards actually approved the CPT ELISA test, which qualifies for medical diagnosis, but it is still something that has to be adopted in the US. But that is the end of our presentation. Here is our reference, and thank you for watching.
Thank you.
Bye.